everyone. I would like to introduce Amira Adawe. She is a manager at Minnesota Children's Cabinet Office of Governor Mark Dayton, where she works on early childhood in all policy and system using equity lens. Amira previously worked at Minnesota Department of Health as legislative liaison and St. Paul's Ramsey County Public Health as a planner, health educator, and community engagement coordinator of Family Health and Community Engagement Division. She is a public health researcher, and her research interests include women and children's health in the area of access in the healthcare, skin lightening practice, and mercury exposure. Amira is the founder and executive director of Beauty Well Project, a campaign to combat the skin lightening practice and chemical exposure in the immigrant and refugee communities in Minnesota and nationwide. Amira is the host of weekly radio show Beauty Wellness Talk at Cali Radio. She is the founding member of So La Home, which stands for Somali, Latino, and Hum Partnership. Hmong, I don't know, I'm saying it right. Health and wellness. Amira has undergraduate degree in family social science from University of Minnesota and Masters of Public Health from University of Minnesota School of Public Health. She was also a policy fellow 2015 until 2016 at Humphrey School of Public Health Affairs at the University of Minnesota. Amira's work has been featured on local and national media, including Star Tribune, MinPost, Stat, National Public Radio, NPR, and Matter of Fact with Soledad O'Brien. Please welcome Amira Adawe.
That was a long introduction. Thank you, Hibo. Thank you, Abdulkader, for having me here and actually inviting me. I've been always wanting to come to Maine and meet the Somali community here, but this is really a great opportunity today, and I'm so grateful to be here with you all. So I'll try to be close to the mic, but I like to walk around. So when I talk about health disparity and equity, I don't mostly talk at people. It has to be a discussion, and it's something that we should co-create and talk about this issue together. And so I'll try my best to do that. I know that the setting doesn't look like that way, but I would like you to all participate. So I'll give a little bit background about who I am, and Hibo did all the introduction, but I would like to talk about my background and why I do what I do. So I'm originally from Somalia. Just like any Somalis here, we all had the same experience. We all had same migration experience, and so I was born in a city called Mogadishu, Somalia, to a mother and father who were very well educated. They both got educated. My father got educated in Russia. My mother got educated in Italy. So they both had Italian kind of background of education, and so the second language of our home was Italian language besides Somali. And so my mother was the head of maternal child health in Somalia, the bureau of maternal child health in Somalia. And my father was military general in Somalia, and so having a middle class family, the war happened at the age when I was at the age of 12, and so we had the same displacement as everybody here. We had the same migration experience from Somalia to Kenya, and I came here 17 years ago. Um, I had to learn English, and English was not my first language, although when we were in Kenya, we were able to learn the language, but that was never perfect, and so in order to be educated here, you have to learn the language. But I always wanted to do public health. Public health was something that I grew around. My mother, at a very young age, I used to watch her do immunization campaign educations in some of the maternal child health districts within Mogadishu. And so I always wanted to do public health. And so when I came here, there was no undergraduate degree in public health. And so I had to go to University of Minnesota to do family social science, which is very similar to social work degree. And then I worked for local public health department. So when I was working local health department is when I saw all the disparities, all the inequities, because I'll go into homes, for high-rises homes, and do home visiting, do health education. And so when you are actually engaged in communities, and this was not only Somali communities, the Hmong, the Latino, even some white groups who were also experiencing some poverty and all of that. And so I was like, in order for us to address health disparities, we need to think about upstream public health, which is focusing on public health policies and changing the system. And so I went back to graduate school, did health policy and maternal child health, School of Public Health at the University of Minnesota. So during that time, I started becoming a legislative intern for the Department of Health, at the time Deputy Commissioner of Health. And so that's when I had my first exposure working with legislators, trying to influence policies. And then from there on, I wanted to do that because that is where you actually have power to influence things. Although I didn't have, as an intern, I didn't have a lot of power, but at least people that looked like me were not there. And so through that way, I could influence some of the ideas of the people that I hear their voices. And so after graduate school, I still worked for the county several years, and then also worked for the University of Minnesota out some prevalence study, which I'll talk about later on today. Then I came back to Department of Health to do legislative liaison work, basically being in between the governor's office, the Department of Health, and the legislatures to make sure that we have policies that work for every community. And so during that time is when I influenced some of the policies, some of them being expansion of family home visiting. So when we do public health family home visiting, the models that we use were never tested in immigrant communities. And so the public health nurse will go to homes, but the models never work for families. And so one of the things that when I was at the Department of Health that I was able to influence was that expansion, but also making sure that we include promising models of family home visiting. So I did that a couple of years, worked on that, and then now my current role working at the governor's office, managing the children's cabinet, which is working on early childhood and all policies and systems. And through that, you get the opportunity to, like I said, many people that look like me at the state capitol or work with legislatures. And so through that, I get to sit in many tables that people decide policies, systems, and programs, even the grant applications that we give to community organizations. So I have that opportunity to work with 7 agencies and influence policies through that way. And so equity and community engagement is some of the areas that I heavily focus on making sure that the state is connected to the communities and and sometimes as a public health people or even as a state policymakers people, we just design things because we think people need. And so part of what I do is that no, we need to stop that and get the solution from the communities because they know what work for them. So that's the kind of work that I do. So before I start talking about health equity and disparities, I would like to ask, can you, any one of you tell me what's the difference between disparities and equity? Come on, it's not that hard.
Yeah, I don't have a background in this, so disclaimer, I don't know. Our equity is what you're trying to achieve, and disparities is the result of discrimination or lack of equity.
Yeah, thank you.
Yeah.
Who else?
Disparities are differences that may or may not be related to institutional factors that discriminate against a population, whereas inequities are more related to those institutional factors. So you can have things that are different that may be disparities, but aren't necessarily always connected to historical discrimination or other things.
Okay. So how many of you directly work with communities? How many of you work directly with communities? Any communities of color or American Indian, if there's any in this state? So most of you have exposure to communities. So so health disparity usually is the disparities among populations, among groups when it comes to opportunity, when it comes to disease incidence and prevalences. Some groups have more higher prevalences of diseases, some have less. And that is what opportunity is what I will talk about later that creates more disparities and health inequities in general. And health disparity also is associated with institutional racism, and so heavily I think the reason we have in the United States health disparity is that long-term inequalities within the system, policies that we design, practices that we do, similar to the structural racism. And so you have some state agencies that you don't even have people of color working. And so how do you serve communities when our hiring practices don't even represent the communities that we serve in? Policies that we design, like I was talking about earlier, if people who are designing the policies or passing the policies don't look like the community or don't even have lived experience, that kind of policy will not be well represented of these communities. So these are structural racism and institutional racism. But also people who are working in the system are discriminated against. And so these things, whether it's hiring process, whether it's policies that we work on, in everything that is interpreted of institutional and structural racism, and that actually increases the number of health disparities in communities. Actually, could you go back? Yeah, the next one. Yes. So before I talk about the social determinants of health, I would like to ask again, what creates health? Just thinking about your own self, your own family, what do you think that creates health?
Everything.
Say more.
Everything, the family I was born into, the environment I was born into, every behavior I was exposed to and adopted or chose not to adopt, the, you know, the access that I have to afford healthcare, whether I have a job that provides me with insurance or not, so I can seek preventative stuff. What have I missed? Every social, environmental factor and maybe more.
Yeah, thank you. Who else?
all all basic needs,
Oh,
just such as uh, housing, water, shelter, all this part of healthcare.
yeah. Who else?
Safety.
Safety.
Safety, yes. Um, yes, so basically, so when we talk about health, a lot of times healthcare comes to mind, and I think many of you know that is very small part of what creates health. Um, by the time we get to healthcare needs, we all have already experienced multiple things in our lives that actually made us unhealthy and need healthcare. So what creates health, 10% is only the healthcare part. The rest, 60% actually are the social determinants of health. When we talk about employment, education attainment, the place and zip code, that is a huge factor where people live, neighborhoods. I don't know if you ever heard about John Powell at the UCLA, Brooklyn, who really talks about place matters. I would highly recommend that you watch his documentary. He talks about how zip codes actually determines your life expectancies. And that is because of the lack of opportunities in these neighborhoods, whether it's education, poor education qualities in these schools, lack of childcare, lack of good access to healthcare, lack of insurance, and all of that. Um, and so employment is a huge thing. Access to food. In Minnesota, our legislatures passed several years ago focusing on hunger and access to food, especially food desert neighborhoods, making sure that the corner store sells fruits and vegetables. Because usually the normal corner stores in certain areas don't even sell that. People don't even buy, it's hard for them to buy organic foods because of lack of money and all of that. So all of these things create health. If people don't have education, they can't get certain jobs, and that actually impacts their income, what they get, and also that also contributes to their life expectancy. So in the last several years, we went through so many processes of talking about health disparities, social determinants of health, and now equity. So we started the discussion with health disparities. We moved to social determinants of health. We learned that these are the things that create health. And now, how do you find equity? And that's the biggest issue that it's going to take us many years to really get to and getting fair process for everybody. So these are what creates health, access to healthcare. Access to healthcare is not insurance only, because people think about insurance a lot of times. I think having healthcare insurance is so important, but also some groups are underinsured. They have insurance, but they pay high copay. They can't, with Medicaid patients, sometimes they can't even find dentists that can help them or take their insurance. And so these also are inequalities because they have insurance, but it's not useful. And so that impacts their health too. And another thing about health access that I've been very interested for the last several years in doing research is that patient-provider relationship, especially Somali immigrants and among communities, these are very relationship-oriented communities. And so when they meet with their healthcare providers, that's not what they get. Healthcare providers don't even have enough time to see their patient. They have like less than 20 minutes to see you. Some patients, they don't even have dogs, and so maybe the provider will say, so how's your dog? I mean, so saying that to Somali elderly, I mean, that is not gonna work. And so they mostly talked about lack of confidence and trust for their providers, and that impacts their health because they don't wanna disclose certain things that they're experiencing. And so these also increases their chances of not getting enough health screening. Some of them don't even do their annual checkup because they don't want to deal with all of these questions that ask them. So one of the elderly, one time when I worked at the Department of Health at the refugee screening clinic, he was tested for TB, and so he tested positive, but he didn't have active TB. And so the nurse actually told him to take isoniazid, which is like antibiotics. But he didn't want to take that because he was like, why will I take that? I don't even have active TB. And so basically in Somali, he told me all the animals that they have been trying on this as an experiment died. And so they're trying on Somalis. And so the mentality of clinical experiment is in their mind that these medications are only to test on them, but not to help them. And that comes from trust and confidence with their providers. And so I think that I heavily stress healthcare access in terms of relationship building and trust. And that is where I think community organizations and community health workers can become really great to bridge these differences among the provider and the patient in terms of cultural understanding in general. So I'll talk about a bit about our state. How many of you have been to Minnesota? Okay. How many of you read about Minnesota or even know what it's like? Okay. Piece of color, particularly in the Somali community. I mean, 1 in 3 children live in poverty. I mean, that is extremely high, similar to the Hmong, American Indian and African American. And so these are some of the huge disparities that we're experiencing compared to the white children and families. It's not the same thing. It's 1 in 10. And so yes, we do have a lot of white communities that are experiencing poverty in greater Minnesota. I mean, and equity, it's not only for people of color, but also including these groups to make sure that they have access to everything. So in general, a lot of groups are not doing well. And I'll talk about later on the investment that we're doing in our state to address some of these inequalities. So these are the rates of poverty in our state when it comes to different groups. And as you can see, Black African American have the highest poverty in our state. And like I was saying earlier, when we talk about Black and African, that also includes Somalis. And so some of the census data does not collect stratified groups, and that is one of the things that we're improving now to make sure that we know specific groups what type of poverty rates that they have. But these are the general poverty rates for all groups in Minnesota. So, racial income disparities, this is a huge part of the social determinants of health. Especially in our state, we have seen disparities among groups when it comes to accumulating wealth. I have been engaging African American leaders for a while, and so there was this African American woman who said to me, in my family, nobody even talked about saving or even financial literacy. It's not something that we grew up learning about wealth. What is wealth? That's not even a narrative that we learned in our households. And so there's a huge wealth gap amongst the groups compared to the white community. And so one of the examples is home ownership. What are the rates of home ownership here in this state for people of color? Okay. I guess that's not something you track. So there's a huge home ownership gap amongst groups in Minnesota, even in the US. I mean, there's a huge literature that talks about that. This is so much in the history during the redlining, the disparity about who gets access to money to buy home, who gets access to wealth. And so that started with African American, discriminated against African American, American Indians, and now new immigrants are experiencing that same thing of lack of accumulating wealth and home ownership. And these are, I mean, home ownership is one of the number one thing of building wealth. And if people don't have access to home ownership or even have access to loans to create their own businesses and all of that, I think that indirectly impacts their health and well-being. And that's not only the individual, but also overall well-being of their communities. And so home ownership has been a huge issue, and our governor has been very intentional in creating loans for low-income families to have access to and buy homes. And now you will see a lot of immigrants like Somalis and Liberians who are buying homes, who are owning homes actually. Not only buying homes, but also opening their own businesses. Somalis are very business-minded people. I don't know the ones in Maine if they have a lot of businesses, but but they are very creative. And sometimes even if they don't have access to loan, what they do is that they have system way of collecting money. In Somali we call a yuto, which is people putting together money and giving to one individual, and that individual will either use that for mortgage down payment or open a business. And so it's really amazing and creative way of actually trying to build their own wealth. And so the state actually recognized that and is now helping them to build their businesses. I mean, every corner that you go to Minneapolis, you will see Somali business owned, from childcare to halal meat store. And so these are access and recognition that they're getting from the state because of what they created, and the state is supported. And again, that has a lot to do with the current administration that we have. Governor Dayton has been very generous to making sure that everybody in the state has equal access to opportunities. So, in the state of Minnesota, black population has been increasing, and that has something to do with the Somalis. And now we have one of the Somalis are the highest in Minnesota. I think the second highest is Columbus. So when it comes to North America, I think Toronto is a bit higher than us, but we as Somalis in Minnesota, we like to think that we are the highest Somalis in North America. but I think it estimates like more than 50, I think, thousand, 80 or even 90,000 Somalis that live in Minnesota. And so a lot of these um, um, residents of Minnesota population, black population are mostly Somali, African Americans that moved from Chicago or other areas in Illinois also live there. So these are refugee arrivals in Minnesota. As I was saying, Somalis are one of the highest refugee results in Minnesota. Like I said earlier, Somalis are the highest after Canada. They all live in Minnesota. So the census says 32,000. And that's not accurate a lot of times because a lot of people don't fill out these long surveys, which we're trying actually now to get ready for the upcoming census, that we make sure that it's accessible to everybody and that we count everybody that's there. But the estimation is 32,000, but it's more than 80,000 Somalis that live. And most of them they come through asylum or refugee, but most of them are, when they when they come to other states, they again remigrate to Minnesota, and so because of the opportunities that are available in Minnesota, or maybe they have family members that live there or friends that live there, so they would like to reunite with these groups. So this is the percentage of East Africans in Minnesota. Somalis are the highest. 82% of Somalis live in Minnesota. We do have Ethiopia too, which is 14. Eritrea, 2%, Sudan, and the other 1% are other East Africans. Like Kenyans and people from Uganda, but predominantly are Somalis that live in Minnesota who are from East Africa. So these are the health status of Somalis when they come, East Africans, and mostly are Somalis when they come to the state. We do have a really great refugee health screening in our state that when they first come, collect all of that screening and making sure that they follow through, that they complete all of their care through the refugee health clinic, and that's a free service, public health service for them. So these are some of the things that diseases that Somalis experience. TB, and that a lot of them don't have active TB, and it's just that latent TB, and that happens like when you live through a refugee camp, you maybe at some point get contacted with somebody who had TB, but it never became active for you, and so they will always test positive. But public health, we do like to follow through that and make sure that they take the 9 months medication to make sure that they don't get active TB. Also, hepatitis, it's very high. hepatitis B, it's very high among Somalis. And now I think a lot of hepatitis C, people are dealing with that. And these are some of the chronic diseases that are impacting Somalis in Minnesota. Other screening that they rate high is STIs. That's becoming very high among young Somalis, adolescent group, and that's one of the things that the address is trying to address and do a lot of educational outreach and making sure that those youth get screened. A lot of times adolescent health is so difficult, they don't even go to their clinics. And so making sure that they come to their clinics and get screened. The other thing is that sexual health is not something that's talked about in the Somali community. And so how do we have kids at school learning that early on? And some parents don't allow that for their kids to participate in sexual health education class. And so these are some of the behavioral changes we're trying to make, that these are just to equip them and learn before the rates of STI gets increased. The other area that I worry about a lot is the lead exposure. People sometimes live in houses that were built before 1978 that tend to have high lead paint, but the state has invested local health departments to make sure that they go homes and clean. But it's still that depends on the landlords too. And so we work on also legislation to make sure that landlords are disclosing when families are moving into homes and homes having lead paint. So these are some of the things that we're trying to address. Sometimes families, they want to live in these houses because of it's cheaper for them. But also part of what I do is that addressing these chemical exposures both through regulation but also educational to educate them. So the other health concerns that I really worry about among Somalis that we're trying to address and educate is the practice of skin lighting. How many of you know anything about skin lighting and chemical exposures? So skin lighting are products, creams and soaps people use to change their skin. These are people who intentionally want to change their skin to lighter skin. And some people use to address skin conditions, but a lot of people intentionally use to change their skin. So these products contain high levels of mercury. I mean, for the last 7 years and a half, I have been working on project to test these products. And so some of the mercuries that are in these products range from 4.0 to 33,000 parts per million of mercury, which is extremely toxic. And women use during pregnancy and breastfeeding. So you can see that mercury is passing through the fetus and through the breast milk, which is extremely toxic. And we do know that mercury causes neurological effects. Mercury also causes kidney effects. So these, it's not only also mercury, but also these products contain hydroquinone and topical steroids, where women mix multiple creams and use 3 times a day. I mean, you can see exposure is so high. When they mix these products, they put in the refrigerator. So the food is in there, drinks are in there, kids are drinking from there. Mercury is also very toxic, that just the vapor of mercury in homes can actually impact everybody that works in that home. So sometimes if the family don't disclose or the individual don't disclose that they using skin lining products that contain mercury, and people are visiting them at home, mercury can stay in homes for months or even years unless somebody goes there and cleans the mercury fiber from home. So that means everybody that goes to that home can get exposed to mercury. So we're talking about that high exposure that's going on in the community. The state of Minnesota, we have good regulation to regulate these toxic chemicals, especially mercury. But other chemicals we can't regulate because we don't have state legislation that's telling us to regulate. We're trying to work on. Federally, I am working with multiple coalitions to make sure that FDA regulates most of these cosmetic skin lighting that contain mercury and other chemicals. But that regulation is ongoing. So what I focus mostly now is to educate the consumers, making sure that they understand the health effects of it, both external and internal, how that will impact their health, but also in general, the environment. These people, when they use these individuals, they just throw in the trash, and that is going into the environment. And so these are toxic products that needs to go into hazardous waste disposal sites, and so people don't even know how to dispose. So these are some of the things that we're trying to help them understand to safely dispose products. And mostly I worry about how kids are getting exposed to this, and that's one of the reasons that I do ongoing research on this issue, but also making sure that educating healthcare providers, public health home visiting groups, but also other public health leaders to make sure that that's an area that we invest our money to make sure that we help these communities. And it's not only Somalis, also the Hmong community, the Latino communities are using. This is also happening in New York, it's happening in California, and it's happening in Chicago. And so it's highly practiced thing. So other chronic diseases, just like other chronic, when people have sedentary lifestyle and eat certain food, they tend to gain more weight, and they develop diabetic and hypertension. So these are some of the things that we notice with Somalis in Minnesota. Similar to uh, also, like I was talking about, mental health, actually, that's a huge, huge issue because of the trauma that people experienced. So we tend to see high issue of rates of mental health, and that's heavily what we try also to address, doing programs that are make that focus on the trauma, addressing the trauma, and being mindful about that everybody experiences some sort of their life mental health crisis, whether it's stress or depression and all of that. But also, since it's a stigma, making sure that they understand what we mean by mental health, because the narrative of where we came from, mental health was something that people never used to disclose, and so that was always an issue. So these are some of the products, skin lighting products that we tested that contain high levels of mercury. And these are products that heavily used by Somalis and Hmong and Latino. And we bought them from the Hmong market and the Somali market when we were testing these products. So now, these are just a few of them, but we tested more than 500 products that contain mercury, and I can't put all of them on a PowerPoint. So these are some of the work that has been happening to address some of the health disparities in the Somali community. So one of the health plans that we have in Minnesota, health plans, doing 5 years of cardiovascular disease study to making sure that that we really understand the chronic diseases that are impacting Somalis. And also they're creating a lot of intervention to address that. The other part that very low attainment of vaccine. I don't know if you're experiencing in your state, a lot of Somalis don't like to take the MMR vaccine because of a lot of them say that it causes autism, and that is not right because we don't even know what causes autism. And so because of that, in Minnesota we have been experiencing measles outbreaks. And so that has been a lot of issue for the state. And then 2 years ago, we did a mental health conference. That was the first Somali mental health conference to make sure that we raise awareness on the issue statewide, but also the community, making sure that they're getting access to all of these education resources. So I won't go talk about much about this, but this is example of, and Abdul Qadir has that on each table, example of what equity means. And so equity is basically everybody getting fair chance for everything. I mean, that's simple. Making sure that everybody has equally access to education, employment, without gaps. I mean, with zero disparities. And I think that has to be very intentional. It's not something that, you know, we can say, oh, we will fund this and this, and it's gonna go well. But the funding also has to be very intentional. Making sure that it focuses on equity, and making sure that, yes, you know, when we're trying to fund small organizations or even any organizations, public health system, we ask them to measure everything. And we're still learning how to measure equity. It's very difficult to measure equity because of the layers that we're trying to address. And so it's going to take many years to have a really good way of learning how to measure equity. And so since you are, most of you funders, I urge you to think about that and think about ways of look, when you're asking organizations to measure, know that it's hard to measure equity. But piloting is always good, and it's not an area that people piloted and studied, but investing in more pilot projects and making sure that it's documented and later on through that way it can be measured. So I will highly recommend that. So this is also what we created in Minnesota to intentionally address inequities and develop health equity. So this was created, our state health department, making sure that we focus health in all policies. Public health, now we don't limit ourselves to only health. We go into employment. We partner with employers, we partner with education, Department of Education. We partner with housing to address housing crisis and increase affordable housing. So focusing on health in all policies. When people are proposing legislation on housing, they should invite public health people to be part of that. And so thinking through health in all policies, I think it's so important. Strengthen community capacity. Making sure that we hire communities and build them, and not only asking them to have traditional degrees. A lot of the people, I think, they know their communities, they know everything, but they just need that vocational training, whether it's community health worker certificate or other trainings that can actually give them more skills. So basically intentionally building the community capacities And I think, Abdulkader, that's one area that we have been trying to develop more healthcare workers in the Somali community. So similar to that, making sure that the communities are built, understanding, could you go back? And expanding understanding of health, like I was talking about earlier, what creates health, because that is not understanding that population-wide everybody understands. And so just thinking through about what creates health, that is not only going to the doctor, but also other things. So this early childhood I'll talk about later, and so for now I am done. If you have any questions.